Thank you, Andrew, and thank you for giving me an opportunity to present here. Thank you, Ken Mayer, for the invitation. I'm going to move now to our experience in the real world in trying to understand the association between expansion of antiretroviral therapy coverage and the impact that this has had in the province of British Columbia. I recognize right off the bat that I have the privilege of working in a very rich environment, and resources, fortunately, has not been a constraint for us, given that we have had a very strong support on the part of the provincial government, who has been enticed to do so based largely on the results that I'm showing you here. Historically, our program has been very tightly aligned with the International AIDS Society USA the therapeutic guidelines, and so as a result of that, we have 3 phases of antiretroviral therapy expansion in British Columbia. The first one following the summer of 1996, where there was a very brisk uptake of antiretroviral therapy. The second one, you're all familiar, the time of treatment interruptions and concerns about toxicities and resistance that went between 2000 and 2003, at which time we reached a steady state of plateau in the number of people on treatment. And then starting in 2003, with this new set of guidelines that came out around that time, we reopened the door to the program, but at this time we had a conversation with the government, and with a better understanding that treatment contributed to both prevention of morbidity, mortality, and transmission, we were given green card to expand our outreach efforts increasingly over the years. The result of that is, as you see here, a steady increase in the number of people on treatment over this period of time. The impact of this in the program will be displayed in the next several slides. The first one that I show you here relates to the baseline CD4 counts in people starting initiating antiretroviral therapy in British Columbia. And you see here that the CD4 count, the median CD4 count, has increased steadily as a result of this. And even though we have a very sort of liberal policy in terms of offering antiretroviral therapy to virtually everybody as per North American guidelines, what you see here is that it takes a huge amount of effort to move the median CD4 count to a very high level. We still have a small or a shrinking and a small number of people that start treatment late. We're happy to see an expansion of the people that start treatment early, but as I said, it's easier said than done. Adherence to HART, contrary to what some had predicted earlier, with the expansion of the program actually has improved. That's partly a reflection of the program being a very solid program, but in addition to that, the fact that our treatments have become simpler, safer, more compact, and therefore they're easy to live with. What you see here is that the number of people that are more than 95% adherent by refill compliance has increased steadily, and the number of people that are very non-adherent, less than 40%, has shrunk quite remarkably. I didn't show the slides, but let me just reassure you that resistance rates have declined exponentially in the province of British Columbia over this period of time. The next slide here shows a composite of the aggregate levels of viral load in the province. This is one way of displaying this. We're trying to put it in a way that you can get the maximum information out of it. On the black, you have people who are undetectable over time, going from 1996 to 2009. It's gratifying to see that this rate continues to increase. On the light gray on the top, you have people who are high detectable, and as you see, this proportion of individuals has shrunk steadily. Let me notice here that for this analysis, we include everybody who has ever tested with viral load in the province. There is a single laboratory that does all of the viral loads. They're all fully subsidized, and therefore we capture 100% of viral loads. In a separate slide that I did include in this presentation, we had the ability to include the HIV positive undiagnosed to give you a more sort of real-world estimate of what this looks like. You would simply add about 20% of individuals to this block of detectables, and that would adjust for it. So there are different ways we can use to make this more or less liberal or a conservative estimate of the projection. Well, I guess I did include the HIV drug resistance. Here you have the resistance that I was alluding to earlier. In the bottom of the slide, these are people who have wild-type virus. In the top of the slide, you have people who have resistant to 3 and 2 drug classes respectively. I think you can see very clearly that individuals with high-level resistance is basically a story of the past. There have been some mathematical modeling coming out of California suggesting that expansion of antiretroviral therapy will be irrefutably associated with resistance. That may well be the case in some settings, but it doesn't necessarily have to be the case as shown in our experience. Moving on to more important endpoints, all-cause mortality has declined in a reciprocal fashion to the number of people on treatment. And I want to emphasize that in the latter phase of our expansion, we still have a demonstrable impact on the expansion of antiretroviral therapy on mortality. For morbidity, this is age new cases. You see the same trend, reciprocal to the expansion of antiretroviral therapy. Even though British Columbia is a jurisdiction that has relatively little tuberculosis, we actually surprised ourselves by being able to demonstrate an association between increased coverage and decrease on annual tuberculosis incidence. We next move on to HIV diagnosis. And what you see here is a set of curves. The first one that I described for you is the old curve illustrating the number of people on antiretroviral therapy. First phase, rapid uptake, steady state, the second phase, and then a slower uptake thereafter. What you see next is on this pink line here, at least pink in my screen, you see the HIV new diagnosis. I remind you that we have increased the number of tests that are being done in the province every year, and yet you see a declining number of HIV new diagnoses that is actually reciprocal to the number of people on antiretroviral therapy. As Tim illustrated, Tim number 1 that is, we don't have a good way of representing HIV incidence, and so what we have included here is the estimates of incidence provided independently by the Public Health Agency of Canada. We don't necessarily agree 100% on the methods that they had used for this, but nevertheless, the HIV incidence provided by them suggests that the same reciprocal nature of HIV incidence and treatment expansion is present. And finally, I added for you here the new HIV diagnosis in individuals who had a risk of injection drug use in the past, or present for that matter. And what you see is a fairly marked decrease in the number of new infections. This is important because in some jurisdictions, this is a population that is systematically neglected when it comes to access to antiretroviral therapy because of the fear that they may be the source of a resistant epidemic. Our data demonstrates that that's quite far from the truth. In fact, if you want to look at actual numbers, prior to 1996, in the early 90s, we were diagnosing 400 new IDUs per year. At the present time, in 2012, that number is 29 per year. This is greater than a 90% reduction in the number of new HIV diagnoses on injection drug users. I do have to recognize the fact that we have fairly aggressive low threshold facilities and harm reduction programs that we use as entry point for these individuals to engage in appropriate care, but they also contribute to decreased risk. Just to give you the same sense for overall HIV new diagnosis, prior to 1996, in the early 90s, we were diagnosing between 850 and 900 cases of HIV per year. At the present time, as you see here, we have 238 new cases. So we're basically sparing approximately 600 new HIV diagnoses per year at the present time, which is great for everybody involved. And this is happening against an environment where predominantly STIs, syphilis, gonorrhea, and chlamydia are all in an unfortunate descent. Hepatitis C has been declining, but relatively at a slow rate. When it comes to measuring the performance of the program, in addition to the cascade of care, which I will not discuss because that was the subject of a presentation earlier this morning, I wanted to bring to your attention what we call the programmatic compliance score that was developed by Viviane Diaz-Lima from our group. And what she did, and I think this is interesting because she took the monitoring guidelines of the IAS USA guidelines and she dichotomized them into what is recommended and what is outside of the recommendation. I won't go into the details, but with that, she created a score for each recommendation that you don't meet. You get a point. The more points you get, the worse off you are. And when you run the statistics in terms of mortality outcome, if you use a 0 score, which would be a perfect adherence to the monitoring guidelines, as your reference, then you see an incremental worsening of the relative risk, eventually 22-fold greater risk of mortality if you have a score of 4 or more. And this is good because it's really putting it back on the sort of healthcare provider and patient labs to work really hard at improving on this outcome, on these particular variables as a means to improving the outcomes. And this can, as I said earlier this morning for the cascade of care, it can be actually monitored longitudinally, and then you can use this as a means to incentivize clinic staff, et cetera, to do the right thing. The kind of data that we have available, you know, I'm missing one slide, is of value to address other issues. While the rates of HIV in IDUs have come down dramatically in British Columbia, the rates of MSM diagnosis are coming down, but they're coming down slightly. I show you here a recent publication showing the rates of syphilis in that community, the MSM community, in contrast to sex workers and heterosexuals. And you can see that if you were to consider this as the background high-risk behavior, then the fact that the rates are going down slowly gives us some reassurance that treatment and prevention is also operational in that setting. The final slide that I wanted to show you is here. We're currently working on characterizing using the resistance testing that is a standard of care in the province for everybody that tests positive with HIV. It gives us an ability to create a phylogenetic map. This is the phylogenetic map for the whole of the province, excluding individuals who don't link to a second individual. And so what you see here is cases of HIV transmission that relate to another person within the province. But what it allows us to do is identify the clusters of transmission. We're currently working with Attorney General to use this as a platform to look at the issue of emerging cases, new cases being diagnosed, mapping them into this background map and identifying emergence of clusters on a real-time basis so that we can direct the efforts of the healthcare system to better target whether it's the locale, the community, the clinic, or whatever where these clusters are emerging from. As we have less and less HIV cases, this becomes a much more important contributor to our decision-making in terms of where the resources can be allocated. We have the ability to link to this data risk factor, postal code, and a number of other variables that will help us to better target our efforts going forward. I wanted to give you one more word of caution. The healthcare system in Canada is a socialized healthcare system, so the services are typically available everywhere. British Columbia is the only jurisdiction that has chosen to make antiretroviral therapy and HIV-related services completely free with no deductibles or copayments, in addition to having a solely dedicated program to fight HIV and AIDS. We believe that that's part of the reason why the new cases in BC are going down, which is a trend that is not apparent in the rest of the country. So it takes a little bit more than just having the resources available. There has to be some energy behind them and some facilitated access if we're going to make the best out of this. I bring to your attention the HIV treatment and prevention workshop. If you want to read some more about this kind of work, the proceedings are available in the website as illustrated here. And I'll also remind you, April 1st to the 4th of next year, we will have the 4th workshop in Vancouver. And if you're interested, I'll be happy to give you further information. Thank you very much.